Hi, I'm Dr. Angela Brown, Professor of Medicine at Washington University School of Medicine and Vice Chair for Health Equity for the Department of Medicine. I'm here with Dr. Daichi Shimbo from Columbia University, and we just had the pleasure of moderating a very fascinating session, late-breaking trials on diet, discovery, and drugs for management of hypertension.
That's right.
So I thought it was great, and we're going to talk about the 4 trials that we moderated.
Yeah. Who knew? I mean, it was an era where we thought, oh, we all already know how to treat hypertension, but we have lots of new evidence showing us that perhaps we can treat it a different way.
Absolutely. Well, let's start with the first trial where, basically we learned that lowering blood pressure is good, which we already know.
Yeah.
But what did we learn most importantly?
Well, what I took away from it is, I think we've all speculated, we all thought that reducing blood pressure would improve your cognition and reduce dementia. But we haven't really had randomized controlled trial evidence on that. And that trial really impressed me. It was a cluster randomized trial. It was conducted in China. There were villages that were randomized, and they were randomized to, these are participants with high blood pressure, hypertension, and they were randomized to intensive versus blood pressure control versus usual care. And over a period of several years, I think that there was a reduction in dementia and also an improvement or less worsening of cognition without dementia in the intervention arm.
Absolutely.
And so from my point of view, I think that is really the first randomized controlled trial evidence that in fact lowering blood pressure is good for your brain.
Absolutely. And I think people will really resonate with that because we all know the toll that dealing with dementia, dealing with stroke has on folks. So I think people will really relate to that. The other thing I liked about it was that they used coaches. And we talk a lot about health equity and community engagement. So if we want to implement something like that here in the United States where our population is much more diverse, we have to be able to adapt and really think from a cultural standpoint and look at the different social determinants that we deal with here in order to achieve the same type of response.
No, I agree. I mean, getting at the point is, can we bring something like that from China to the United States?
I think we can.
I think we can.
Absolutely. Well, let's move to the second trial, and with that one, that was, which one did we talk about second?
That was called the POP-HD trial.
Yes.
And that was a trial looking at patients who had gestational hypertension, previous gestational hypertension, and also those with preeclampsia, who had given birth, and they're in the postpartum period. This time is actually known almost amusingly as the 4th trimester. Just to highlight that in fact, even though it's post-pregnancy, it's still a critical period. And I think you and I know that that period is important for, if blood pressure, glucose, and other things are left unchecked, you're really at increased risk for cardiovascular events in the future.
Exactly, the long-term implications for women, particularly who have preeclampsia, are not only significant for them, but they're also very significant for their offspring. So my takeaway from that is this is a perfect opportunity, I think, for us to really double down on prevention. If I'm a preeclampsia baby, education needs to start early so that I know what my risks are down the road so that we can start decreasing some of these numbers of negative impact.
That's right. And for our audience, the intervention was home blood pressure monitoring along with a physician involved, titrating medications versus usual care. And I think that they saw reductions in systolic and diastolic blood pressure on 24-hour ambulatory monitoring. And what I got struck by is that not only did they reduce blood pressure, but they also looked at LV mass and other echo measures, and those were also reduced as well in the intervention arm.
Those were also very well, had a very nice response to as well. If we think about the third trial, again, something that we always talk about, and that's sodium reduction. And we know that lowering sodium in the diet is good. But again, we saw a very significant reduction in blood pressure by lowering sodium. Even if you take people who are on a high diet, transfer them to a low sodium diet, and then that was a crossover study.
That's right.
And so those who were started out on a low sodium diet and went to a high diet, you actually still saw that reduction in blood pressure.
Right.
But interestingly, we didn't see a significant increase in blood pressure for those who were not hypertensive.
That's right. Those are, my understanding, those are individuals who were given a usual American
which
high
is
salt
very
diet,
high in sodium.
and then they added salt on top of that.
And which is what we do.
That's right. Yes. And there was a little bit increase, but it wasn't significant.
It wasn't significant, exactly.
Right. But there was a large reduction in blood pressure when they were put on the low sodium diet. Right. What did you get away from that trial?
I was really struck by the fact that, again, I think it's an opportunity for advocacy, for us to really reduce sodium in our processed foods. Yeah. The majority of sodium does not come from the salt shaker, and so until we really follow some of the FDA recommendations, get industry on board for sodium reduction, again, I think we can do it. But it's going to be a struggle, and there are other countries that are working on this, but it's very important for us to have that industry buy-in for us to improve health in this manner.
And one thing I liked about it, just to riff off what you're saying, is it looks like all groups benefited. Whether you had hypertension or not, whether you were on BP meds or not. There was a signal, as you know, for those who had diabetes. It looked like they had a greater reduction in blood pressure with low salt diet. But of course, the study was so small, one wonders if that's really a true finding or not. But I think that's something that should be explored, whether diabetics.
We definitely need to explore that. And then the final thing I'll say is that, in the discussion about that, we talked about the social determinants again. In order to do this, we really will have to address food deserts, food insecurity, the cultural nature of sodium in the diet as well. So it has to be a multi-action platform to address this, but very important. And then our final study, which is getting to the drug discovery, something new, because it's been a while since we've really had anything new from a drug standpoint for hypertension. So what did you think about messenger RNA targets?
Yeah, so this was a drug that is an RNA interference agent. It's how do you pronounce it? Zacerin, I guess that's how it's called.
I think so. I stuttered over it.
But it's an injectable form. You only give it every 3 or 6 months.
Which would be great for our patients who have an issue with compliance
that's right.
or adherence.
And they saw a very large reduction, substantial reduction in angiotensinogen, which is a precursor to renin, of course, the ACE pathway. And they saw 80 to 90% reduction. And along with those, they saw a significant reduction in both systolic and diastolic blood pressure that were sustained over 6 months.
I was very impressed. And in addition to that, the side effect profile or the adverse events, very low.
That's right.
They did point out hyperkalemia, but very mild and not needing to be treated.
Yes. If you were to tell me 5 years ago that you could treat hypertension with an injection,
I would say no way.
I would say no way, that's incredible.
Way.
No, but really, very promising evidence. So
I think this could be a game changer for us.
Yes, I agree.
Definitely a game changer. One other thing that I liked about this trial is they did have very diverse representation.
That's right.
There was a large African American component, and there were other underrepresented populations as well, where they saw a positive decrease. And that's very important because, again, our population here is very diverse, and we all know that in African Americans, hypertension tends to come on earlier in life, tends to be more difficult to treat, and the outcomes tend to be worse. So this could really be a game changer because the effect was very good. And again, this was phase 2.
This was phase 2.
This was phase 2, so we need that longer, more involved phase 3 trial. But again, very, very promising.
Absolutely, I agree. I was excited.
Very excited. So, I was very excited to do this session. It did not disappoint because once we heard the presentations and the discussions, I think we got some great information out of it, and it's really going to be information that in the long run will help us decrease morbidity and mortality in our patients.
Right.
And put the focus back on hypertension.
Absolutely. And I just want to end it all, it's like we're only in day 1. I know. How much of the meeting, how much information is now been disseminated and presented? I think this is amazing. I'm so happy to be here.
Well. Thank you.
Yeah, thank you.